Hi, good evening, and welcome everyone. This is our fifth session of the RFS webinar series on leadership. At the beginning, I just want to give a quick introduction and overview of our program. Leadership webinar series were developed by Monica Useda and members of the RFS Women in IR Committee. The goal of the webinars is to educate, support, and encourage interventional radiology trainees and early career physicians to build successful careers, acquire leadership skills, and potentially obtain leadership positions within the healthcare system. With that in mind, we developed 10 monthly webinars and invited some of the most prominent IR faculty to present on a variety of topics, including communication, negotiation skills, health policy, team building, diversity, and several others. So today we are going to talk about one of the most important topics for development of a long, successful career, teamwork. As the saying says, if you want to go fast, go alone. If you want to go far, go together. And we're exceptionally proud to welcome a pioneer and one of the most prominent IR leaders, Dr. Barry Cutzon. Dr. Barry Cutzon is a founder and chief medical executive of the Miami Cardiac and Vascular Institute that was first of its kind multidisciplinary approach where cardiovascular specialists work together in a unique multidisciplinary infrastructure that now modeled throughout the world. Dr. Cutzon is also a professor of radiology and surgery at the Interventional Radiology Department Chair at the Florida International University Herbert Verheim College of Medicine. He is a founding editor of Techniques in Vascular and Interventional Radiology Journal, as well as chief medical editor of the Endovascular Today. Among his tremendous clinical achievements are the first renal angioplasty in the United States and collaboration on the team creating the first intravascular stent, which is to us sounds like just unbelievable achievements. And he is also a recipient of numerous awards. Dr. Cutzon was awarded Gold Medal of the Society of Interventional Radiology and was the first American to be presented with Gold Medal Award from the Cardiovascular and Interventional Radiology Society of Europe. He received Career Achievement Award presented at the Transcatheter Therapeutic Conference for pioneering life case education and his worldwide leadership in endovascular medicine. In 2011, he was presented Julius Jacobson II Award for Physician Excellence by the Vascular Disease Foundation. This is truly unbelievable honor to have Dr. Cutzon sharing his story and role of teamwork with us today. And thank you, Dr. Cutzon, for joining us.
Well, thank you, Alex, and thank you for everyone on the RFS. I think it's such a great initiative program that you have, and it's been a great pleasure seeing what's happened at the young level, and the interest in leadership in particular is so critical to the growth of our discipline. I thought what I might do this evening is share with a little bit of some of my experience with teamwork. And I have to say, after hearing your introduction and looking at the whole program, the one thing I'm not going to address, and I kind of feel maybe I'll try and deal with it at the end, has to do teamwork in our own practices. That is, practices of interventional radiologists in general, with each other. I think at some point I will mention that, but I'm going to focus mostly on how important it is for interventional radiologists to be able to interact with other disciplines in a way that results in creation of clinical teams, improving the value of IR to those teams, and importance of IR in the clinical setting. I assume everybody's seeing the slides. That's the new front entrance of the expanded entrance to the new institute expansion. And I'll tell you a little bit more about how we got to this point, because I started like everyone else with a lab in the back of the hospital someplace, and it's grown into be a large organizational structure, I would say almost entirely based on teamwork. Teamwork really can be the difference between success and failure, frustration and happiness from a professional point of view. And the ironic thing about it is that's something that it's in the control of all of us. So with that said, I'm just going to, let's see, advance slides here. Make sure I get on. There we go. So I thought I'd talk to you a little bit about multidisciplinary culture at the Institute, trying to understand the benefits of collaborative treatment models to patients, physicians, and our allied health personnel. Trying to understand what you have to give up for teamwork, some challenges to actually executing, because obviously, as Alex said, you can't do it by yourself if you're creating a team. We really have to have everybody on board and everybody engaged. Talk about some clinical examples. Talk to you about some financial issues that could be important, because when we start sharing things and doing cases together with other disciplines, the real world, the rubber hits the road in the real world sometimes as it relates to financial issues. So before moving to Miami to establish the Institute, I actually had two successful IR programs I built, one in New York at St. Vincent's Hospital and another one for 12 years at Alexandria Hospital. Neither of those are sustained today in the same way they were. St. Vincent's, I think, is now an apartment house or something, and the lower village, any of you that might be in New York. But IR remained important till the end. And then the program at Alexandria Hospital, which actually flourished into a teaching program, has become quite different and probably more traditional in an organization. But we have built staying power here in Miami, the program that we started in 1987. And you'll very rarely hear me say I, by the way. It's something I try and avoid using that term at all, because any success is always a result of the we. And I try and teach all of my colleagues to really never use that in lecture or any other format, because we have so many people that contribute to our success, not the least of which are our patients. So there was a lot that went on, because I moved to Miami with the vision of creating actually a patient-centered care model, multidisciplinary disease management model, all the things which didn't really exist. So to accomplish that, there were a number of political and collaborative entities that occurred, including at that time using the non-invasive vascular lab as really a micro model of what we could do on a bigger scale. Probably about a decade or so later, in the mid 90s, we did, I think, our first endograft in 1993 in Miami, 4, something like that. We created a multidisciplinary and economic entity, bringing radiologists and surgeons together to do this in a teamwork fashion. Then probably about 15 years ago, I led, along with the head of a vascular surgery program, the actual merger of a group of vascular surgeons who we'd worked with for a long time with our large radiology group. And that still exists today, 15 years later. The world is very different, but there hasn't been a divorce. I'm no longer part of the group, but it has been sustained over time and brought great benefit, I think, to both sides. And then finally, to create teamwork on a more systemized level, meaning aligning everybody's interests in getting everybody to work together, we created the first in the United States multidisciplinary management company in partnership with the hospital to actually manage an entire service line, including cardiac, vascular, and IR. But I grew up in the time of great turf battles, not so much when I started, because nobody wanted to know what IR was doing. In fact, most vascular surgeons opposed it. Cardiologists had no real interest in it. But then as the procedure became more validated, it became clear that angioplasty was going to really be potentially disruptive. That's kind of where many of my original ideas came from. And in the vascular space, which I'm going to focus on because I think that's one of the areas that has the greatest tumult and cardiovascular turbulence, let's say, we have a lot of different disciplines who have an interest in the vascular space. And at a time when I started, nobody else was doing vascular intervention. In fact, I think one time in the United States, something like 95 or 96% of all vascular intervention was done by interventional radiologists. But there were others who touched it, And we began to see that there's a potential conflict that could be developing as these other disciplines became more interested. These various disciplines that we sort of touch had a much more remote relationship with each other. And in fact, one of the reasons I moved to Miami was because I noticed for peripheral arterial disease or hypertension or stroke, you basically had all these different disciplines treating the same disease, but not really talking to each other, not really connecting with each other. And if you're a patient who has hypertension, you have stroke risk, you have heart attack risk, you have PAD or gangrene risk. Nobody's really putting them all together, and that's really I say that was back in the early 80s. I wasn't smart enough to coin the term patient-centered care, but certainly the center around disease management structure became very interested to me. So pre-2000, you had these various disciplines that would overlap a little bit. Vascular diagnosis was performed in a lot of different areas, but people were in the periphery. And then after 2000, we began this sort of collision course that led to a lot of different conflicts. And there was some attempts among leaders at that time to create something called vascular centers of excellence. The idea being that if you could create a vascular center or an entity, where the rules of the game were maybe different. We all live in medical staffs that have medical staff organizations, but if we could create something different that had different rules, maybe we could create, a different kind of environment. So I began to develop my own feelings about multidisciplinary collaborative efforts, really recognizing that different specialties probably bring some asset to treatment of patients. I did come to believe very quickly that turf battles were destructive to both the physicians that were involved, and I really learned pretty quickly that when you have two different disciplines or two different people involved in a big turf struggle, they wind up both losing in one way or another, and in the end, our patients are the ones who really lose. On the other hand, if we could figure out ways of working together, you get 2 + 2 = 5, or 1 + 1 = 3, that sort of thing. And I became a very big believer and executed on that model, as I'll share with you moving forward. From a leadership point of view, we're not all leaders. Many of you are probably leaders because you're interested and you're taking this sequence of program. But a leader who can't get anyone to follow is not very effective. And so it's very important for leadership to be successful to really put your person in the other's shoes and really understand what's driving them. What are they trying to get out of this? What do they need to create value? And work on creating win-win situations. This has been something that's driven me philosophically, and why at one time in my career I was accused of putting some sort of elixir in the drinks of our vascular surgeons because they were so collaborative and so whatever. But it was really always about creating win-win situations. In a competitive world, identifying the real competition is everybody else, other institutions, other groups, so on, rather than each other. That's the secret sauce. So let me take a step back and talk a little bit about technology, because we live in a super technology world. We live and thrive on technology because that's what helps us make healthcare less invasive, what we do less invasive. Many of you may be aware of Clayton Christensen. He wrote a book that was a very influential book called The Innovator's Dilemma. It's still a good read. And he actually described the term disruptive technology. I kind of recognized the concept that it affected how I approach things, but I wasn't smart enough and wasn't a good enough writer to identify these two. But here you can see what those differences are. But importantly, disruptive technology changes the infrastructure, changes who does the procedure, what the procedure is. It changes virtually every single thing about it. And if you take an example like the digital C-arm or portable C-arm, you start putting X-ray or fluoroscopy, or you put ultrasound in the hands of others, it has all kinds of an enabling effect on what others can do, and therefore disrupts the field by changes who uses it or controls it. And as you probably know, radiologists tend to be big control freaks about who does what in departments and so on and so forth. And that's the world I grew up in anyway. How they use it, where it's used, what it costs, and how it influences others. And when you start thinking in these terms, angioplasty as an early pioneer And I was doing angioplasty before balloons. If you really want to think old, I did my first peripheral angioplasty in 1974, before there actually even were balloons. And it became clear that this was going to be a very disruptive technology, and that we as radiologists could not survive and stay in this space, in the status quo, without doing something about it. So I began to look at different models and figuring if we could avoid turf battles, and try and develop another kind of medical staff model where everybody engaged, that would be helpful. Now, regarding clinical care, and I know that this is part of the RFS mission. I was reading some of the documents you have online. For me, it was never a question of changing the clinical. I could never understand why radiologists were the only discipline in medicine who didn't take care of the patients they did procedures on. There was no other procedure, no other discipline that did this. So for me, from the very get-go, the first time I started doing anything, I started providing the clinical care associated with whatever I was doing, diagnostic or otherwise. But not being a clinician, or considered to be a clinician, we were looked at very pejoratively by other disciplines, and so that was another problem. And we had the other disciplines involved in those Venn diagrams were clinical specialists who controlled patients and a number of other things. So that became a very early rationale, besides just quality of care and my own interests, and why it was so important for us to be clinicians. So again, we had existing medical staff structure that had boundaries and politics that could be barriers. So when I first moved to Miami and I started talking about admitting patients, well, they say, well, how are you going to do that? Who's going to admit the patients? This was all talked about in general. And so part of what we had to do is change the image of what an interventional radiologist. And one of the uncertain things was whether we needed economic integration for this thing to be successful, meaning did we all need to be in one group so we shared economically, or could we create a model where everybody respects everybody else, contributes, and work the rising tide kind of philosophy? Anyway, we had a lot of thoughts, and this was 86, sorry, where I wrote this sort of 3-page white paper. It was actually on my Alexandria Hospital stationery, sent this information, and ultimately decided to move here in 87 to Miami. And we were established in 1987 as a physician-driven entity with hospital collaboration. And here you can see some of these things, but some of the principles were strategic commitment to minimally invasive therapy, as you see there, measurable performance, multidisciplinary care around the patient. That was in 1987. And patient care centered by design. These were all written into our initial concepts. Of course, the other thing is we were going to treat the cardiovascular system as a single entity. That links radiologists who only had an interest at the time in peripheral stuff with the cardiologists and the surgeons and everybody else involved, that we were going to work together. Also, we established and said right up front, turf battles are destructive. We've got to figure out every possible way to reduce those. We established principal disciplines of the Institute. Here you can see them. I'm not going to read them off. And secondary disciplines to support the patients that were involved. We had strategic planning, very important, by the way, those of you that are looking at leadership, when you're looking at consensus building, strategic planning is a very important process to get everybody to think and talk in an environment outside of work, and ultimately to come to some general consensus about directional control. And here you can read what that mission and vision was. And the problem really is we had all these people doing a lot of different things where there was a lot of overlap. Think about all these disciplines who were using the same facilities, the same infrastructure, and so on. But clearly, as seen here, there was a potential in many places where everybody was fighting for the same patient or access to the patient. Seems a little crude, but the reality is patient care really is and should be a team sport. This goes back to the I that I mentioned earlier. So some of the things we did regarding multidisciplinary relationships in general is we changed quality assurance or peer review from a single discipline, meaning only a radiologist could define the quality of a radiologist, in this case invasive and interventional, or a cardiologist or a surgeon, and everything became patient-centered. So our peer review committees This was a foundational part of MCVI. Became chaired by two different disciplines generally, and included all the disciplines involved in the care of a specific area, cardiac or vascular or whatever. And no single discipline had a majority. We've been organized by service lines, and this still exists today. It is a source of great pride, I think, for the physicians that are part of MCVI, and they're highly defensive of anybody who proposes something else. And then, of course, we began to formally incorporate innovation. So let me talk to you about some political problems and some solutions. When I moved to Miami, I came to a hospital, wasn't much more than an Elsewhere General, had about almost 400 beds. I knew we wanted to create this this integrated vascular service, cardiovascular service. Actually, it was always cardiovascular from the beginning. And it turned out that there were 4 or 5 vascular services in the hospital. Vascular surgeons had a lab, the neurologists had a lab, radiology had a control of ultrasound, which was evolving, did not have the proof and use that it had now for vascular application. And nobody wanted to give up anything. So within the radiology group, I came up with a proposal, which obviously brought the hospital in line because they didn't like the idea of having duplication of services. And there were different components of each of these labs. And I convinced the radiologist to give up control of vascular ultrasound in return for a guarantee of 1/3 of all the vascular lab work. And then the other disciplines would be involved in the other 2/3. That model actually still exists today, and the vascular labs control multiple hospitals and things like that. But it became a microcosm, and the medical director then actually was a neurologist at the time. We formed the new vascular lab, closed all the other things, and we had a new non-invasive vascular lab, which still exists today, a program that's much more bigger and complicated. But so what are the mechanics here? So what we did is it's a tactic I always like to use, which is don't worry about changing the status quo. Create something new. Try and find something new that's bigger and better. Create a bigger vision than what you have. And this became a microcosm of where we were going with the endographs, with the institute, early on. Some of the other innovative things we did regarding multidisciplinary collaboration were when endographs came along. So I think I was the only radiology PI in the United States of any endograph trial early on. We had to fight our way to get radiology involved, by the way. That's another story. But our surgeons didn't know what was coming. We knew that this was big, even though it was primitive. And we took advantage of that extra knowledge by saying, look, we're going to do all these things with a team. Of course, they all required cut downs. There was no percutaneous access or anything like this. And we guaranteed that ultimately, if this technology worked, we're going to make sure everybody on the team has the ability to perform these procedures. We weren't doing it to control the surgeons. And so they actually got very involved very early. They really had very little understanding or vision of the future at the time. We created the endovascular team where we agreed, as a matter of policy and quality, that all cases would be done by a joint team and the revenues would be split equally by creating a new economic entity that would bill for this new team. We were all in private practice at the time. For the Institute, some of our pillars of success are obviously being out there and being the best clinically, creating multidisciplinary solutions and involvement. This isn't really sexy because you can see a beautiful new building, you can see a high-tech environment, but you can't see multidisciplinary collaboration or teamwork. The people who see it are the patients, it turns out, who write letters and say, listen, we knew everybody on the team was working on our behalf. And people actually sense this and feel this. It's really interesting when it becomes part of culture. Obviously, research, medical innovation, and the commitments to less invasive therapy, as I mentioned. So all this led to a very rapid success. We ultimately consolidated. We were growing all over the hospital with multiple things. We started in the back, a couple of rooms in the back of emergency room here. Each department voted actually to become part of the new and expanding institute. And we opened a dedicated building in 1993, as you see here, with a number of us looking quite a bit younger. And that was a rendering of the first institute, which was, by the way, called Miami Vascular Institute. It was called vascular because at the time, we felt vascular meant the pump and the pipes, and we were trying to convey that. and the cardiologists were in on this always. But it turned out that everybody thinks vascular is veins, probably even today. It wasn't a great marketing position. So our name changed over the years in a variety of different ways, and now is what it is. So at the time, we were really pushing technology, but from the beginning, the Institute was always intended to be an integrated care facility. And in 2000, we actually had a chief of nursing that was highly collaborative, believed in the teamwork model, and supported us really becoming a hospital in a hospital within a hospital where we could control the quality of patients from the time they came into the door to the time that they discharged. And that resulted in us ultimately having 100 inpatient beds and 30 outpatient beds, with everything rolling up to us leading the Institute. So it actually became a hospital in a hospital within a hospital at a point in time. These are some of the disciplines that are involved. I'm not going to spend a lot of time on this because our function's on leadership tonight. But it led to a lot of innovation, a lot of support, none of which could have happened without this, because among other things, the hospital and the organizations that we work for are much more willing to invest capital and provide financial support when they see physicians working together. Well, the interventional cardiologists were growing, and obviously, you know, vascular was getting all the press at the time. Cardiologists only had angioplasty. Tables are reversed now because structural heart is the hottest area in less invasive therapy, really. But obviously, one of the things we did is we supported our cardiology colleagues in accomplishing it, because we were kind of the leaders here. And we helped them in a lot of different ways, which was tangible and intangible, and secured our relationship with both interventional cardiology and, in fact, vascular surgery. Obviously, we encouraged publication early on because we were building this from scratch. So today, where we are is we are, of course, a hospital within a hospital, but now MCVI is 6 hospitals, about 50 outpatient centers, about 1,200 employees, including 83 physicians that are physician members of MCVI, of course, including the interventional radiologists. I'm happy to say that even though I'm obviously still the founder and chief medical executive, but we have a management company that I'll talk to you about that I just resigned from, and the new chairman of the board happens to be an interventional radiologist who got elected. Go figure, you know. And one of the cardiologists is vice chair. So give you some idea of the respect we've been able to earn because of this collaborative model among our disciplines. I'm just going to skip real quickly. For those of you that don't know, we just recently completed a $120 million expansion. That's a fully integrated environment. The white rooms that you see there on top were actually the old institute. Everything else represented new construction. But the thing I really want to leave you with a little bit as we zoom in here is you can see all these suites. The area at the bottom is all the surgical environment. But these suites are actually interdigitated. So the rooms alternate between interventional radiology, interventional cardiology, neuro. So and there's a common control area there. So we've actually created an environment where all the disciplines work side by side, and they're not separated. And it's a great example of how architecture can be used to express a philosophy and eliminate the them and us, and create a first-in-the-world environment that's pretty spectacular. If you haven't seen it, we look forward to showing you that, showing and having you for a visit. So what happened was, I mentioned the vascular lab. That was the very first model, multidisciplinary, really tangible model. In 2010, it was the largest vascular lab in the United States, and now it's still only one of a handful that's actually accredited in virtually every single discipline. I mentioned the new relationship with vascular surgery surrounding endografts, but I'm sorry about that typo. I don't know where that came from. Sorry about that. But the next real significant growth in terms of collaboration actually was a complete merger between a group of our vascular surgeons. There were 5, and the interventional radiologists, and then the radiology group as a whole. And the only reason I want to talk to you about that is because when we first brought up the idea, well, first of all, when I brought it up to my IR colleagues, they said, "You're totally out of your mind. We're never doing this. Why do you need to do this? You're the king here. Why don't you just tell them the way it's going to be?" And I told them at the time, I said, "Look, if you want to build a sustainable model, everybody really needs to be engaged. Authoritarian models generally don't last for very long." But anyway, so the IR said no, 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 and over the next year and a half, the IRs voted unanimously to proceed. And then I went to the executive committee of the group, who they said it's never even going to get out of the executive committee. Anyway, so one of the things about leadership and teamwork is there does have to be a leader, but there also has to be perseverance. And I think if you create the right story and you're doing things for the right reason, and you remember the win-win, and you also remember that people are very resistant to change. So if you mention anything that represents a change, it's going to be interpreted as a change for the worse, and it's going to be met with resistance. So I think the first thing you need is perseverance, patience, and stick-to-itiveness. So convincing everybody that we're all in the same boat and our futures are really intertwined is an important thing. Now, I've always been, I want to share with you one quickly. This is a little more complicated, particularly people at your stage, but it is an important model because it's also about 15 or 16 years, and it represents a way of aligning physicians with institutions as well as with each other. And as you know, many physicians today are looking at employment models of different disciplines, a little less so maybe in radiology, but whether you're an employee of a major academic institution or a venture firm or private group, you're still an employee generally, even if you're a partner. But in any event, the key to progress was alignment of everybody. And so we proposed and ultimately developed something called the MCVI Management Company. It's a way of moving money from a hospital, let's say, to physicians by paying for quality, not for paying for volume or anything that relates to financial incentives for bringing money, anything like that. That's a no can do. And it's all based on performance and quality. And I'm very quickly just going to share this model because it's interesting. It may have other applications. We were the first one in the United States to do this as a full service line, and maybe still the only one really doing that. The advisory board, a national consulting firm, has done stories about it and so on. But basically, if you look from the top down, there's basically two 50-50 partners. One is all the physicians. They own 50%, and the hospital owns 50%. So it's unusual in hospital arrangements. And from those two 50s, you form this LLC, which is the management company. And today that's called Miami Cardiac and Vascular Institute Management Company. And then this entity signs, in our particular case, a contract with the enterprise health system that pays for quality. And that's the way money is distributed back to the owners. So there's basically two ways to get money. It comes from a base management company, so we actually pay for physicians to attend meetings and do whatever. And then if we reach quality metrics, then that's where the bigger payoff comes. MCVI is responsible for all these parts of the service line. It includes IR, obviously, in here. The management company is. There are things that we don't do, and I'm not going to go through the organization, but here's the kind of thing that it goes. So let's say we want to have a quality target that only 1% of surgical morbidity is favorable. So we look at what the outcomes are, and as long as we're below that level, there'll be a certain payment that will come to the doctors, and it's all shared equally, by the way. And here you can see the way we look at what these measurements are. We look at what the mortality rates are, and we kind of define this is what we feel is the ideal mortality rate for quality. And these represent thresholds of quality that are established by the physicians in conjunction with administration. And then in addition, each of those is backed up by a number of incentives. It's kind of way too complicated, but for today's discussion, but I'm happy to talk to anybody. We have a lot of people coming for site visits about that particular engagement method or alignment methods. So this goes back to the beginning of TAVR, if you look at the last bullet. So when TAVR came along about a decade ago, obviously, we already had this culture. So when it came time to form the first TAVR team, guess what? The interventional radiologists were part of the team. So one of the interventional radiologists went with the team to train on the original the device, and were involved in the early research and clinical things, and we were able to significantly reduce, of course, the vascular complication rate. And now we're available if we need it, and for any type of issue. So I will talk a little bit about teamwork in the clinical space. This is myself, an interventional cardiologist and a vascular surgeon. In this particular case, I think we were working with him to use an Amplatzer or something. But one of the advantages of working together as a multidisciplinary team clinically is that you're not a carpenter. You're not a carpenter with a hammer looking at a nail. You don't only think about the solutions you can create. You think about the solutions we can create. And if you need surgical skills, or you need interventional cardiologist, or you can really take advantage of this translational knowledge to do things like this, where this patient has has had an acute replacement of their aortic arch, and now has this big pseudoaneurysm that you can see here. We felt we could not, coming from above, really put this precisely there. We'd have risk of not getting in, getting to the cusp, and how can we do whatever to get there? And so before we even had a TAVR program, we went to the cardiologist and our vascular guys and said, look, the simplest way to correct this is to let us use a transapical approach, which is what we did here in an angio suite, by the way. Here you can see an endograft coming up through a transapical approach. And here's what it looks like after perfect position of an endograft to close that tear. And so we find ourselves working more and more with multiple disciplines in complex cases. This happens to be the interventional team, while the vascular surgical team is working. And then for things like this with CLI, and things like TCAR and things like that, having extra hands and skills are really helpful. And this happens to be a case that's now a lot more common, but you want to go from the groin and then go from the foot and meet up. And showing you this to just show, this is a pedal axis, as you can see here, femoral axis up above, and ultimately we meet in the middle, and we're able to correct this patient's problem. And probably the most interesting thing about this, let's see if I can move forward, is that here we have myself, a vascular surgical colleague, and one of our senior techs working together. And so we have a highly collaborative environment. You look at this kind of a lesion coming from the transverse aorta, bulging out of the patient's chest, and think about how you're going to correct something like that. And now we can sit as a team and say, okay, well, if you do this part, that I can do that part. And well, when you meet with everybody as a team, you all of a sudden start looking at tools that you wouldn't have available otherwise. And in this particular case, our cardiac surgeon and a vascular surgeon working across from him are working. We're occluding a left subclavian by putting an Amplatzer in the left subclavian right here. Then the chest is open. Again, this was in our angiogram. We did 1,200 EVARs and TVARs in a regular angio suite. So the cardiac surgeon did the bypass. Then we came up from the groin, put the endograft in, and wound up with an excellent result. Then there was some question about whether there was adequate flow to the carotid. Because we're in the right place and because we had the right people, we could very quickly make sure flow to the right carotid was still intact. So multidisciplinary models and teamwork. Today, multidisciplinary models include physicians in different disciplines, nurses, technologists, and other allied health personnel. Everybody needs to have a role for decision making. When we do cases, our work environment is anybody can speak up, and if they think something's wrong or they have a better idea, let's hear from it. If it's a tech, a nurse, the anesthesiologist, whatever it is. In the end, it's all about high quality performance, clinical outcomes, and market competition. And all of these are team sports and not individual sports. So how do you get, so obviously you guys who are here tonight are all interested in leadership. I mentioned earlier, leaders without followers tend not to be really effective. So again, I wanted to try and leave you with a couple of thoughts here. One is try and think about creating value and measurable benefit. If you go for the goal that's worthwhile to everybody, you're fighting for a cause, you're going to be much more likely to be successful. Don't be afraid to involve all stakeholders. I've been criticized frequently by my partners when we were partners about talking to people who might be considered adversaries for fear of letting them know what we're thinking or what we're doing. I've always felt it's much more involved to engage them. If they want to commit suicide and not be involved, that's up to them. Ultimately, all of this can help leading to cultural change, which is the way you sustain teamwork. It can't be done if it's all dependent on just having the individuals and not creating the value. Ultimately, it won't be sustainable. I'm going through that problem, by the way, right now. We have a TAVR committee that's part of culture on the cardiac side. One of us, vascular team, and the cardiac radiologists go. But the vascular guys don't think having an EVAR team is that great an idea, meaning pre-decision making with everybody. Everybody works together on the cases. But so we still have issues of implementing change. I've been very impressed that things, if they are successful over time, will be embedded into culture that you as a leader don't necessarily have to defend. I've also been impressed with the ability to foster creative thinking for patient care. If you're interested in innovation and being better than average, and not just being state of the art, but being ahead of it, you're going to have creative thinking that goes out of the limitation of your own box of tools. We're all trained in a certain tunnel, and getting out of it sometimes is challenging. And then finally, if you're working for an enterprise, if you want capital to get the support you need, when they see multidisciplinary collaboration, they're much more willing to write checks. So I think with that, that's the end of a formal presentation. I hope I've given you a little bit of insight. I mentioned at the outset, I wasn't really talking about interventionalists working with each other so much, but I'll be happy to address that if you wish.
Wow, Dr. Cutson, thank you so much. This was just unbelievable story and very phenomenal, several ideas, both economically and clinically. I have no words. I have a few questions for the start because I was listening and several things were just amazing. So I have a question. You mentioned that you have this, you implemented your experience with vascular surgery, and how would you translate that to our work with urology and OBGYN? Because it seems like right now there is a lot of work trying to work together with urology for prostate artery embolization, trying to convince them to give us some patients, and a lot of practices kind of struggle to do that. How would you translate your experience with vascular surgery and cardiology?
So you're sort of commingling a couple of things that I think in the end what you're really trying to do is advance a procedure that you have no primary access to patients. And that's where the beginnings of vascular intervention were. So I'm going to address this from a couple of points of view. The way we built a practice model that was built on competition, meaning that even today, while we may not be able to get enough patients to sustain 5 or 6 interventionalists full time, we get a substantial amount of direct referrals of patients. And provide longitudinal care, so that if an internist, for instance, has a patient who's complaining about dysuria, and the internist is somebody you relate to, and they know that you're interested in prostatic embolization, or more important, treatment of BPH, is the way I would put it. I think you have to look at it 2 ways. I would say, look, I'm going to get involved in the treatment of benign prostatic hypertrophy. Understand that disease as well as the urologists do. Does understand the the options and be able to talk to a patient, not just about what you do, but what the options are. That's one of the reasons we've been successful on the vascular side, carotid side, whatever it is. So I think that's one part of how do you build a practice with prostate. One would be communicating directly with referring docs, meaning the internist in this particular case. Two would be to find one or two collaborative urologists. I mean, I think within our own practice, we have some urologists, particularly from the cancer center, who are supportive, and they just send patients themselves. But without, I think this is a little bit the way we built UFE programs, that is probably going to have direct patient access. I know I've talked to a lot of patients that are looking for PAE. Now, regarding models with the urologist, let's talk about that for a minute. So one of the reasons they're not referring patients is because they don't do it and they're not involved. Okay, and the fundamental, inhibition to refer somebody out when they are interested in that. I think the data is increasingly, obviously, supportive of PAE. The black box warnings have been removed. There are label indications and so on. So one of the things you could do, and we did this in the early days of coronary CTA, we said, okay, we're going to train all the cardiologists that are interested in doing CTA, and we're going to create a cardiac CTA service. And if you want to be trained, we're going to train you along with us getting trained. And you'll just have to, you're welcome to be a critical thing. You just have to devote the hours. Of course, there wasn't enough money or whatever for them to actually do it. But having made the gesture wound up being a very supportive thing towards the CTA thing rather than putting up the wall. I'm not sure whether to recommend this, but, forming teams with urologists to see patients. We have a women's and health center that's done at one of our institutions where the IR sees patients along with the GYN doctor, evaluating patients with fibroids, have some kind of joint decision making, look at those kind of models maybe, Alex, to see if there's a window. You don't need everybody. You need, one or two guys who are willing to form something. You could form a prostate program, but include the urologist involved, have joint visits, something like that.
Okay, thank you so much. We have a couple more questions. We have one from Alex Logson, and he's saying, thank you very much for taking the time to present. For those of us interested in leadership and entrepreneurship, what general advice would you have for IRs in training and early career?
Yeah. Well, I think it's the old keep your ears open, and I would say a couple of things. Once you get into a hospital, well, first of all, if you have the opportunity to take any kind of executive leadership course along the way, if you're at a university and they have some sort of a healthcare leadership thing that gives you a couple of more initials after your name, that would be a good thing, because, and I don't have that, by the way, but people have gone through MBAs or executive MBAs. The things that they learn most about is teamwork and building teams and understanding that you need teamwork to solve problems, whether it's in business or medicine or whatever. But I think a couple of recommendations I would have. One is pay attention to what's going on with administration and how things are managed. We're going through a time of great change within healthcare. It's in 5-7 years, it's going to be quite different than it is right now. There's a real shortage of physician leaderships in medicine, and most hospital administrators understand that they can have all kinds of great ideas about how to change or improve healthcare, but without physician leadership, they can't do it. So if you have a genuine interest, think of ways that ask for ways that you can be involved. We have people I have people coming to me all the time, and we'll figure out ways for them to engage. Second thing is, depending on what you do, when you're in a committee, in a hospital committee, this is something I told my partners all the time. Some of them listened, some of them didn't. Now they're living with the effects of that. When you're in a hospital committee that involves medical staff and administration, I would look at each of those committee meetings as an interview, where you're being interviewed. How you behave, how you conduct yourself in terms of the professionalism, how you conduct yourself is very, very important to other people, particularly when you get through the clinical humps. I think whatever you can engage in with, there's a number of leadership development programs that many healthcare organizations are doing. We're looking at working with HBS on a couple of things, but don't be afraid to roll your hands up, get involved with peer review, utilization review, cost reduction efforts, sustainability efforts that are going on. All you have to do is volunteer. I'm sure you can find a way to get engaged. But if you have a chance to get a degree or take specific schedule, you know, once you get into practice, it gets very hard to do that.
Thank you, Dr. Cudson. We have one question from Caleb Haberger, and he is saying, thank you for the phenomenal presentation. Can you expand on your quality outcome measure model? And are you using that to adjust reimbursement?
Yeah, so from the very beginning, I've always believed in defining quality in measurable terms. The quality involves, so what we have is we have a service line that includes cardiac surgery, interventional radiology, interventional neuro, interventional cardiology, medical cardiology, and so on. And so what we did for each, the mechanical way we did this is we defined using generally national benchmarks. So let's just take cardiac surgery for a minute because it's out of everybody's comfort zone and you don't know any better. So let's say we want to say we're going to have a business model built around quality. So the first thing we did is establish thresholds. This is the minimum level of quality we expect for us to be considered a good to excellent program. And generally, what those thresholds are, let's say CABG mortality rate, a return to the OR rate, and patient satisfaction, which is important to institutions because they're paying half of it. Now, if we meet 2 out of those 3 thresholds, then underneath there's about 15 indicators, all right? What the ventilation time is, what the amount of blood transfusion is, not so much length of stay because that's related to productivity, but let's say ICU stays, things like that. And for cardiac surgery, there's probably about 14 or 15 indicators. Okay, so let's say there's $100,000 that's put in a bucket for quality for cardiac surgery. And if you meet the thresholds and you meet all of the indicators to the maximum extent, you can make $100,000, let's say. However, if you meet only one of the 3 thresholds, then you make none of the $100,000, okay? If you make 2 of the 3 thresholds, you're eligible for all the indicators that are below that, and each of them they're divided in thirds, basically. So let's say if you're doing, I think one of the things the IRs chose as a quality, not the threshold, but as a quality indicator, is they wanted to have 80% of all patients with PAD that had peripheral interventions discharged on statin therapy, or 90%. So let's say if they only made 80%, they'd get X amount of dollars. If they made 70%, they'd get X amount of dollars. So that can be scaled a little bit. But that's kind of the general way. So it's a pay for quality model. The other thing is that if the interventional radiologists don't meet their goals, then not only do they suffer, but also the vascular surgeons, the cardiologists, everybody suffers because it comes out of the bucket. So we basically aligned everybody with each other. And what that means is that when the interventional radiologist, or let's say the interventional cardiologist, is struggling with why is their STEMI mortality rate not at X number, everybody's weighing in. You know, the interventional radiologists are talking to the interventional cardiologists at committee meetings about how they can improve things. So it's a great way of creating engagement.
Thank you. We have one more question from Joelle Wazen, and she's saying amazing perspective on interdisciplinary collaboration. What advice would you give IR departments at institution where more senior disciplines such as vascular surgery have control over referrals and vascular procedures? How can we reach out?
Okay, that's a great question. I think the vascular space right now is pretty well defined and pretty stable, actually. It seems that there's probably maybe a third, and a third, believe it or not, of peripheral interventions being done by radiologists, vascular surgeons, and interventional cardiologists. So that's around the country. And there are places that interventional radiologists do no vascular work, and places where interventional cardiologists don't do much vascular work. For instance, at ours, I mean, we have a couple of our hospitals are open. The interventional cardiologists could be doing it, but they're not, just because the level of quality is so great and it's historical. So that being said, I don't think the vascular surgeons are the solution, because you're looking at them sending you the cases. The way to start a vascular program from scratch is the way we teach our fellows here. And it's basically to build from scratch as a clinician. Every discipline in medicine is trained at some place to go out and build a practice, except for radiologists. Radiologists are told to join another group, to, or with a contract, whatever it is, it's sort of the work's going to continue going. So I would say, even in an academic institution, one of our former fellows, for instance, works at MD Anderson, and she is interested in forming a vascular program in a cancer hospital. Why? Because patients are living a long time with cancer, and they get vascular problems, and she knows how to take care of those patients. So she's building a vascular lab, and she's opening an office, and meaning a place for patients to go. So I think the first thing we need to do is have somebody in the group that's trained and actually knowledgeable about vascular disease. Now we're getting into clinical practice, rather than depending on referrals from the vascular surgeons. I think there may be situations, there's no real reason for a vascular surgeon who's, let's say, endovascular trained to send a case to a radiologist unless they're too busy or they're not interested, because it's part of what vascular therapy is now. So the question really is, if you as an interventional radiologist want to be practicing in the vascular space, how do you do it? And the first thing you do is you get clinical training. You've got to get it in, we've got to change our training programs big time, to be able to provide that clinical space, that clinical training, so that you can stand eye to eye and you can sit in the patient. I mean, I see patients, for instance, with ascending aortic aneurysms. Why do I see patients with ascending aortic aneurysms? I'm never going to do a procedure on them. All right. I see them because I'm a vascular physician who knows a lot about that disease and can advise patients and give them the advice from someone who doesn't do the procedure. And I think that you have to have that scope to your clinical knowledge, so that you're seeing PAD patients, that you're also managing for claudication, that you're putting on walking programs and things like that, so that you can be the solution for the internist or whoever sees that patient primary care. I don't know, that's a long way around the question, but I think the solution is generally in ourselves and our own clinical training and competition. I think we're competing in a discipline that has at least 3 disciplines practicing in that space.
Thank you, Dr. Hudson. And probably more as a follow-up, the question for me, you mentioned all this clinically based practices, but do you see any new practice models that could be created in the near future, which not just clinically based, but completely different, like with, I don't know, whatever you can envision?
Well, I think one of the things that's happening right now is the movement of some interventionalists into outpatient labs, where they basically do just that. That's not a practice model. It's a way of independent practice where you can, practice what you feel you were trained to do. There's a lot of controversy around that, but definitely the directionally we're going. I think the nature of interventional radiologists is that we are in general highly collaborative. We want to work in team models. Everybody that we work with doesn't necessarily feel the same way, unfortunately. So I think I think what you have to do is when you finish your training, really decide what you want to do, and make sure you find the model. It may not necessarily be in the geography that you're looking for. That's frequently a problem, or where your spouse's family is, or all these other things that come into play. But if you're really committed to being a clinical IR, you got to make sure the ingredients are there for you to be able to be successful. It's very hard to swim upstream. We're not going to be successful 100% of the time. But if you believe in it, do your best to get there. There are several models that include multidisciplinary groups. As we see, multidisciplinary like groups that include everybody. There's generally room for IR. One of the great things about a group practice is that, and one of the reasons we merge with the surgeons, is to take money off the, if you take money off the table, people can generally think a lot clearer about what the best thing is for them and what the best thing is for the patient. And there's a lot of different ways of taking money off the table. When we brought the surgeons on, we had a compromise because the fair market value for vascular surgery in our community was lower than for IR. But we had to put value on the surgeons joining our group and working as a single team. So I don't know that there's a definite model for the future. I think the first thing is being a great physician and being a great technical person at what you do if you're a proceduralist. But I think there's going to be a lot of options.
Thank you. I believe Jason also has some questions. If you...
Sure, Jason.
Thanks for everything so far, Dr. Katzen. This has been a really, really great dive into some of these models. As I think about all the places I've kind of worked, rotated in, studied in, it really seems that MCVI kind of stands out in my mind now as this really incredible story of collaboration. But bringing it back down to our teamwork series concept here, what has been your greatest pitfall in leadership while building these teams as it relates to more general team building concepts?
Well, first of all, I think it's a great question, and I guess in a talk like this, it comes across like everything I've done is successful. And I think it's a great question to ask. And in that context, I want to shift a little bit because IR is tending now to work in larger and larger groups of IRs, and I found in my own group. So let me just say that as I've built my practice, and because I was originally one guy with one fellow, and and when I moved to Miami, we have more when I was at the other places, and I took the deliberate approach to making sure that we didn't all do everything the same way technically. That it wasn't like my way or the highway or whatever, and I created opportunity for each of the individuals to grow professionally, make their own name, and so on. And frankly, just to give a shout out, every single person that's part of the team that I built here could be a department chair someplace, and I'm extremely proud of all of them. But if those 5 or 6 guys don't work as a team, it creates a real problem. And I can give you some examples of that. If you're a big luminary guy, if I was a 1 or a 2-man group and I was doing a huge volume, could probably do this a similar volume, and there's a clinical trial, for instance, I'm going to be very successful in that clinical trial. And participation in clinical trials, by the way, is very, very important part of, if you're ambitious about your practice, very, very important for a lot of different reasons I can address. But and so if you're a 2-guy practice, you're working together as a team. As you get to be a 6 or 7 person group or an 8-person group, it gets harder and harder, in my opinion, to get everybody to work synchronously as a team. And I think, and actually it requires, there's different styles of leadership. You can have authoritarian leadership. You can have hand on the tiller leadership, where there's no question that you have authority because of your title or whatever. I've always led by influence, not by title particularly. But at some point, you absolutely have to have leadership. So in a case of 6 or 7 or 8, if they don't act as one, they're actually acting as none as that group gets bigger. And particularly as IR starts to become more subspecialized, those kind of pressures on whether a single IR can do everything at the same level are going to be increasing. So I'd say one area, that opportunity I felt like I could have done a better job is actually internally in our own group, and that's despite the fact that we've had 2 presidents of SIR. We have another one on the way. In my opinion, we feel a huge obligation to lead the field, but I'm talking about in our own environment, getting people to agree on things like product and inventory, and the stuff where you have to have agreement. You have to, if you don't look to administration like you're one group, it becomes problematic. So that's one area. I think the other area I probably failed is, I think we have tried for a number of years to move into the outpatient space. We're very closely aligned with the hospital, and we sort of failed to convince them on that. Now they're going to be doing something, but I don't know. Beyond that, I'm really sorry I can't think of more, because I know I failed a lot, but I tend to forget the bad stuff, and I also tend to forget the past. If it's not something like this, I'm totally thinking about the future. That's a whole other talk. So
That's amazing. Thank you. And that's an amazing way to look at life for pretty much all of us.
I do want to say, because I didn't show any, I was worried about time, whatever. But whatever success I've had personally has been due to the most incredible group of partners and colleagues that I've worked with throughout my career, that could have gone anywhere else and chose to stay and grow and be part of what's happening, not only in IR, but in other disciplines. And the only other thing I would say was that in the end, all of us, especially when we talk about innovation and all the new procedures that we're going to be doing, people used to look at stuff I did or done and say, wow, how could you take that risk back then, and blah, blah, blah. And I think we always have to remember, it's not us taking the risks, it's our patients taking the risks. And I always remember them.
Thank you, Dr. Katzen. This was absolutely amazing and phenomenal webinar. I think we should probably, if anyone else has any questions, you're welcome to write them right now. Otherwise, we're already slightly beyond 8 p.m. So I think we're going to end this session, and this is it was an amazing webinar. We learned so many things from you, and not only from teamwork perspective, but also from clinical work, from economics, administration, leadership, just too many things to learn from you. And thank you very much for everyone who joined tonight, and thank you for great questions. For those who could not join the webinar this evening, we recorded the webinar, and it should be available to watch at YouTube RFS channel. And our next webinar is coming, I believe, in 2 weeks from now, and we will keep everyone updated. So thank you so much, Dr. Katzen.
No, my pleasure, and thank you all. You guys are all the future, so I know it's going to be a great one for all of you.
Thank you so much. Thank you. And
okay.
everyone have a good night.
Everyone.